So maybe I'll just start quickly by introducing myself. I'm Dr. Abigail Hirsch. I'm a clinical psychologist, and I'm also a co-founder of Lin Health. I got introduced to this incredibly fascinating world of science around chronic pain about 5 years ago, and it just caught my interest so much that I felt like it was essential to found a company and bring these kinds of information and models for working with pain out in a big way. And that's what Lin does. But I have a special guest today. This is going to be Q&A with Abigail, but Jordan, who is one of our coaches here at Lin, but also a great, fascinating guy in his own right, is at the last minute agreed to step in and have the conversation with me. Jordan, maybe you can just tell everybody a little bit more about yourself.
Sure, yeah. So my name is Jordan Kelly. I am a physical therapist by training, but I got into the world of chronic pain through a couple different avenues, one of which just being working in clinic, working with my degree and finding that it felt like we were missing the mark with most people with persistent pain. And it felt very frustrating to not be actually addressing a lot of the factors around pain that were informing their experience a lot more than I was able to address by telling them, okay, go home and do 2 sets of 10 repetitions of bridges, for example. And I love bridges as an exercise. They're wonderful, but it is when pain is informed by so many different factors of our lives, it feels neglectful not to be able to address those all. And found Lin just through a couple of different courses I was taking and just fell in love with the team here and the mission. And so that's what got me on board now.
Well, we're very lucky to have you as a coach and a team member. And with that, I think we're kind of actually have a nice queue up for our first question here. So let me go ahead and put that up. And so first question that we hear all the time, and again, thank you for people who submitted this. Why do so many people have chronic pain? And just to give a little bit of the statistics behind this, 1 in 5 Americans are currently experiencing chronic pain. It's probably the most prevalent medical disorder out there. And it's an incredibly important question. Why is this going on? You know, is there something about our world today that we've just all damaged our bodies in this modern society? Or might there be something else? So maybe I'll just start taking a stab and then Jordan will chime in as well. One of the drivers of chronic pain that is really surprising, and I'm sure we'll get into this more, is that pain is not just about the physical experience, but it also goes with things like stress and anxiety, and those have also been on the rise. So maybe this is because I'm a psychologist. You know, if you're got a hammer, everything looks like a nail. Well, if you're a psychologist, everything looks like behavioral health. But the truth of the matter is, it's very clear that there's been a surge in anxiety, stress, depression, and it's gone right along with the surge in chronic pain. And we are starting to understand the science a little bit better about why that might be, and we will kind of loop around to that. But Jordan, I'm curious your thoughts. Where do you go when you say, why do so many people have chronic pain?
Yeah, so I look at this partially from a medical perspective and partially from a sort of sociological, cultural development perspective. So from the medical perspective, and you know, having worked in a lot of medical systems in the past few years, seen multiple up close, we, you know, since the 1950s when penicillin was invented and modern Western medicine really took off, we've been able to cure all of these things that are previously were a death knell, you know, bacterial infections, multi-traumas from a car accident. We have all these techniques, and as the science has progressed, we've been able to do more to prolong life and to resuscitate life. But the shortcomings of that model and the ongoing development of technology in medicine is that we think that we can always get to the root of a problem with just the best possible imaging and with surgeries that are super targeted. And the issue with something like pain, which is persistent pain is less an issue often with what's going on inside the body, and more an issue in terms of one's holistic wellness. The reason why anxiety is so tied into it.
Yeah, so I really like that. So you're kind of coming from the side of saying, look, we've kind of gotten used to looking at a world that says, well, we should fix this with something medical, and something actually in expecting there to be a interventionist fix, something in our expectations maybe is fueling this epidemic of chronic pain. It reminds me of my absolute favorite study around pain. That has to do with whiplash. There a bunch of researchers in Europe that were kind of observing something super interesting, which was that in Western Europe, there's a ton of whiplash after car accidents. And in Eastern Europe, there was basically none. And they set out to figure out why this difference, because, shouldn't a car crash is a car crash. And if you're bonking your neck, you should have the same impact. Whiplash should be the same everywhere. So they simulated a car crash. They I don't quite know how they did it, but somehow they made the windows break and put a huge sound on, and drove a car right up to behind the car that their participants were in, but didn't actually have a crash. Although the experience was, sounds and everything made the feeling that this had been a car crash. So what's super interesting is in the participants that were from Western Europe, even though there was no car crash that occurred, so they couldn't possibly have gotten whiplash, about 10% of people, 15% of people experienced whiplash even several weeks out after this, neck fatigue and soreness, several weeks out after this non-car accident. When they did the same study with the population in Eastern Europe, nobody got whiplash from a fake car accident. And so the researchers dug in and kind of tried to tease back what is going on here. And what they realized was it had to do with expectations. That in Western Europe, like in America, we've all heard about whiplash, and we know car accident, dangerous, probably going to get whiplash from that. And all of a sudden people got whiplash, not fake, their necks really hurt, real whiplash. And whereas in Eastern Europe, there was not a culture of lawsuits around whiplash, and nobody got whiplash. So I'm going to kind of leave that kind of mystery there right now. But we at least have some thoughts on why people may be getting chronic pain. And I'm going to go to question number 2 on our list here. Question number 2, what is neuroplastic pain? That is a mouthful. All right, so I'll take this one first, Jordan, and the next one you go first up. So neuroplastic pain, that is, yes, a mouthful of a word, but we can kind of tease that out very simply. Neuro and plastic. So neuro means our neurons, and basically that means our processor in our brain, our neural circuits. And plastic is my favorite word ever in this context, because plastic means able to change. We used to think that our brains we learned, I'm sure everybody has heard this, you learn as a kid, but then when you get older, it's all stuck and we don't learn anymore, and where our neurons stop growing and stop learning. Well, it turns out that that's kind of hogwash. Our brains learn and develop all of our lives. And so plasticity, ooh, that's a mouthful too. When we talk about pain or about anything with the brain, has to do with an ability to learn new things. So neuroplastic means pain means related to the learning in our brain. All right, Jordan, just because I've been talking so much, what does that have to do with pain? I get now what the word means, but why pain? Where's the connection there?
Yeah. So there are a lot of terms that are very similar to neuroplastic pain. They get thrown around. And because this is such a relatively new concept in the medical world, there's a lot of, there isn't full consistency yet on terminology. That's part of the reason for in ICD-10, when they're now talking about primary versus secondary pain, they're trying to make it more concrete. But really how that relates to pain is we're now understanding pain as a learned phenomenon, meaning with no fault of one's own, because it's not like we told ourselves, yes, I'm going to learn pain today. I'm going to sit down and do that. But that similarly to learning to ride a bike, similarly to learning a language, plasticity, that concept of neurons forming new pathways with each other, underlies the capacity of the brain to turn pain up and turn it down, to learn how to create pain from either a previous injury or from other factors in one's life, such as anxiety, depression, trauma. There are a lot of different factors that inform it, but that concept of neurons being plastic with one another both explains how we get into such persistent pain and also offers us a way out of it.
Yeah, another thing I like to think about when I once we have neuroplastic pain is, and I'm not going to use the big words, nociceptive and et cetera, but let's just talk about it in human terms. There are kind of three different places that drive pain, right? So one is the one I think we're all used to thinking about, which is some kind of a damage to our tissues or our bones. So for example, I step off the curb and I sprain my ankle and there is tissue damage and I say, ooh, ouch, that hurts. So the signal is there's some damage in the tissue. It's picked up by the neurons. They carry that signal all the way up to my brain. My brain interprets it and says, ooh, pain. So the second source of pain is actually in those in the nerves itself, right? In the system that's carrying the messaging. Sometimes the nerves get damaged or for whatever reason kind of stuck misfiring at the level of the connecting line. And so kind of like you can get static in a phone line. Well, back when our phone lines were actual lines as opposed to satellite data being shifted all over. But when they're a line, the same way you could get static in a line, you can also kind of get some static from the nerves. But the last kind of pain that we used to think was not very common, and now we know is probably 85, 90, even 95% of persistent pain, has to do with the last part of the pain. And this neuroplastic has to do with the brain's interpretation. And yeah, Jordan, like you were saying, our brain is learning stuff all the time. It's the incredible engine that drives engine and computer that drives everything that's happening in my body, right? I lift my arm. It's not because my muscles lift my arm. It's when my brain says, time to lift your arm. And then my muscles react. Vision, there's all kinds of studies that show that if your brain isn't able to process the light that's hitting your retina and activating the nerves, it's not that light and the nerves that are making you see, it's your brain. It's your brain figuring out what's going on in the world and telling you how to experience vision. Same with smell, works the same way. Taste works the same way. Really interesting kind of examples. When you look at places like an optical illusion or that phenomenon where you hear your name called, but nobody was there calling it, that our brain is interpreting the sound towards something that it's familiar with, right? Something that it's learned, which is our name. We hear our names a lot. And so we tend to hear it sometimes, even when it's not going on. But back to the case of pain, it turns out that our brains, when they've been exposed to pain or stress or fear or any kind of danger, because pain is our body's way of protecting us. When you've had that exposure, and we all get it sometimes, the brain starts to learn and it says, ooh, pain's going to keep you safe. And the more it learns that pain can keep you safe, the more it tends to turn that volume up and up and up. And so the nice thing, just going back to neuroplastic pain, because the question was, what is neuroplastic pain? Is plastic means it goes both directions. We can learn something new, but we can also unlearn or learn a new thing on top of the new thing, which means that pain that has a brain component is very real pain. It's not made up pain. It's what pain is. The same way vision and smell and taste are all very, very real. But it's also pain that can be really turned around by learning some new techniques. And I just realized that I kept the slide up the whole time, even though I was going to flip it. But why don't I go ahead to our next question here, and then I'll get us back to kind of talking mode instead of staring at a boring question on a slide. Okay, I got an MRI and back surgery, but it did not help me feel better. Why didn't the treatment work if imaging showed there was a problem there? Jordan, kick it off for us.
Sure. Yeah. So there are, this is the situation that a lot of folks used to come to me in clinic with when I was a practicing physical therapist. And this is what a lot of folks come to us at Lin with as well, as, the MRI showed something, the surgeon was either willing to or insisted on doing some surgery there. And I still have pain. And the thing is that you may have had a issue that was spotted on MRI, sorted out through surgery, but also had a primary pain component on top of that.
And just because we've really introduced primary pain, by primary pain, we mean this learned neuroplastic brain component to the pain experience.
Yes, exactly. Yeah. So if we're sorting into primary versus secondary, if there's an issue that truly needed surgery to prevent something much worse from happening, for example, resection of a tumor is an example of this. We should resect that tumor, right? We're not going to be able to learn our way out of that tumor. Nonetheless, a lot of the factors that contribute to a primary pain experience and that can last beyond surgery, because it has a lot more to do with pathways in the brain than the specific site itself, those can continue to last afterwards and often are not as responsive to pharmacology, not as responsive to physical therapy, things aimed at the tissues themselves. And so it can often be really frustrating if you're a patient who's gone through this whole experience and then comes out the other side and is like, my pain is not better. It's not responding to all of these things. What is there left for me to try?
Yeah, that's absolutely right. And, I think also a lot about post-oncological pain here. Another great example, there's a phenomenon that happens for quite a few people that, they'll go through treatment for cancer, which can be very unpleasant. The cancer will recede. They'll be 100% cleared from a health perspective, but will still have, really acute, really uncomfortable, painful pain, real pain, even though their body is completely healed. And it's very much the same phenomenon that somewhere along the path, along the course, their brain learned pain. And again, not by anyone's intention, not in a way that was deliberate or faking it. This is very, very real pain. Pain just has this learned component to it. And so when you're in that mode, the way out is also through a learning experience as opposed to through a more medicalized experience.
And just to jump in real quick, Abigail.
Yeah.
Somebody had asked, just while we're on this topic, if we could define secondary pain as well.
Oh yeah, great. Thank you so much for jumping in with that. Yeah. So secondary pain is pain that has to do with, so remember we talked about there's three kind of sources of pain. There's the learned component to pain. There's pain that has to do with damage in your tissues and pain that has to do with damage in your nerves. And so secondary pain is pain that's coming from damage to the tissues or to the nerves, which actually brings me to another of my favorite kind of pain trivia pieces here, which is about MRIs. Because I see you smiling, Jordan, because in this kind of medicalization and all these incredible fancy new tools, so MRI is definitely one of them. MRIs have saved countless lives. We're able to see things happening in our bodies that we never would have before. But unfortunately, in the case of back pain, we made a little medical blooper, which was that we only initially put people in MRI machines when they were really expensive who had back pain. And when we put them in the MRI machines, we found, lo and behold, there are all these things that look like maybe they would be causing the pain, like a slip disc or a herniation or a spondylitis. Oh, I can't ever say that word, but
Spondylolisthesis.
yes, thank you. See, I'm a psychologist. I can get away with that. So we saw these things and said, "Ooh, I bet that's what's causing the pain, right?" Because that's like how everyone would think if something doesn't look perfect, you think it would cause the pain. Well, it turns out pretty recently, someone had the brilliant idea to stick a bunch of perfectly healthy people kind of across the lifespan, across different ages into MRI machines. I guess they got less expensive and felt like we should try that and just look at what do normal, healthy, or normal bodies of people with no pain look like, normal backs of people with no pain. So it turns out that all of those findings, they increase with age. But even by like age 40, 30, 40, 50, you're seeing 50, 60, 70% of people will have those findings, even though they have absolutely no pain. So what we've learned is that most of those findings are kind of like my beautiful gray hairs here, and I got wrinkles too. All of these things that just, they're just what happens to bodies as we age. They don't cause pain, but they're a normal, healthy part of the aging process. So it's really important when you are considering back surgery to have a really frank discussion. I mean, first about in the beginning, should I be considering imaging or not? And are there some other ways I can check out, is my pain maybe more of this primary learned pain that won't be responsive to surgery without even needing an MRI? And the answer is yes, one can do that. And we do that all the time here at Lin. But definitely when you're considering surgery, to have a really frank discussion about, hey, are those findings from the MRI clearly causative of my back pain, or could they be what's called an incidental finding, which is these things that are just kind of normal as we're aging? Anything else you want to add on that topic, Jordan?
Just a quick clinical story of having had, somebody with persistent back pain of years, over a decade, who had come to me recently in clinic and hadn't had an MRI done of the back, but had just kind of always figured he had sciatica just because of how things presented, and finally got the MRI done, and unfortunately wasn't given much guidance, was given access to the full MRI results, but wasn't given much guidance on how to interpret them. And so there are a lot of big words in there, like, partial spondylosis of these two segments, mild to moderate stenotic narrowing at these segments. And fortunately, he brought it in and we could talk about it and kind of, parse through the results, say, okay, just about everything on here is something we'd find on a person's back who doesn't have back pain. And so, and the likelihood of that increases over lifespan, as Abigail was saying too. So for you at age 50, there is a 70% chance you would have this without having back pain too. And because we could talk about it and decrease the fear around it, that was ultimately a helpful part of that therapeutic process for him. But without being able to talk about it, all of those big words popping out and all of that text and all of those findings really can just, play a lot of games with your head and how you are making decisions after that, which can be really difficult to navigate.
Yeah, no, that's right. Well, actually, one of the questions I really like asking people to think about when they have back pain is, think about when you saw your first imaging study and just what were the thoughts and the emotions that went through your head. And for many, 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 many people, it's some kind of a fear, danger, unbroken thought. And because pain is our body's way of protecting us, it's super attuned to those thoughts. So when I have a thought of, ooh, this must be dangerous, my back must be broken, I must be hurt, it's at a subconscious level, signals our processor, oh, I better turn on pain because I got to keep your back safe. And so sometimes you actually have like an increase in an acceleration in the primary pain component to something that might have just been like a normal, like little tweak that was going to go away in a couple of weeks, which happens to all of us a lot because of having got those MRI findings.
Mm-hmm.
Again, not to say that one shouldn't use an MRI when it's appropriate, but to really be thoughtful about what was your reaction to what you heard, and do I really need this imaging to be done? So let me pop up our next question here, and here we go. What do you suggest as alternatives to opioid treatment? Great question. So I want to start with something that's actually coming from the CDC, which is just to debunk the myth that opioids are horrible. Opioids aren't horrible. And actually the CDC has actually reversed out of its guidance that said, like, stop prescribing opioids no matter what. They are complex, right? They can lead to addiction. They can lead to a lot of problematic results. They also have a tendency to not work as well over time. So people tend to need more and more opioids if they're trying to mask a pain sensation with opioids over time to get the same amount of pain control. But they're not evil, and there's a time and a place for careful, thoughtful use of them. So having said that, I think in some ways I tend to think less of alternatives to opioid treatment, but more as things that you should be doing no matter what, especially if you are or considering using opioids. And those are treatments that are focused on how do we tone down that brain signaling of pain. Treatments that help teach you how to separate that kind of danger response from the sensations in your body. So we're not accidentally driving ourselves deeper and deeper and deeper into a cycle of chronic pain. What about for you, Jordan? What else would you suggest here?
Kind of just along the same lines as you were just talking about, Abigail, I think we have this idea that either you are thoroughly addicted to opioids and dependent on them, or you are a super athlete training all the time who uses ibuprofen once in a blue moon. And there's so many levels in between. And so many folks who I work with who use opioids, and, sometimes it comes down over the course of treatment. Sometimes it doesn't. Typically, if we're getting good results with their pain, though, through considering this holistic approach, the opioids come to feel less necessary. And you can accomplish safety and pain reduction through other means while still using them as well. So don't like to take them off the table or tell anybody, like, yes, if you are really looking to get serious about getting rid of your pain, you got to get rid of opioids. It's not that simple.
Yeah. I will share again, this is Abigail sharing her favorite research studies, top 10, maybe that's another webinar we'll do, top 10 research studies. So there's some really interesting kind of medical lore around the effectiveness of telling somebody they're getting an opioid and giving them sugar water or salt water as an injection that can work basically as well as the opioid as an analgesic. But another set of studies that are really, really interesting, and I was thinking about these, Jordan, when you were talking about kind of coming down off opioids, is that one can actually learn to pair something else to the opioid. So when you take your pain medication, you can do it with either a mantra or a routine, or even a sugar pill, or some kind of a vitamin you're taking maybe. And your brain will actually start to learn to pair the relief that comes and the sensation that comes with the opioids to that other thing. And so if you do that together for a period of time, kind of intentionally, you can then start to wean off the opioid and keep the other piece in place. Again, I would suggest doing that in consultation and with some help, and making sure we're getting this pairing really strong. But one thing we'll often do when we're helping people then who choose and who say, like, I'd like to reduce the amount of opioids I'm taking, is we look for some of the new things they're learning about how to settle their pain responses down and pair that to the opioid. So sometimes it's a mantra that says, I'm safe, my body is safe, and I'm taking this opioid because I've gotten used to it. And they just say over and over, I'm safe, my body is safe. And over time, they find they need the opioid less because just that thing that's been paired to it creates a lot of the same response.
So
Crazy
cool.
stuff. Yeah, it's super cool and super crazy how powerful our whole learning system is. So here I got one for you to grab next here, Jordan. My pain flares are totally debilitating. I find it hard to believe that a behavioral approach to chronic pain will be helpful. Curious to hear your thoughts. Great question here. I'm so glad to hear. This is how so many of our members come in when they're starting, saying, but this hurts so much. There's no way that this could be driven by a learned neural circuit habit. Is there any way these kinds of techniques could really work for me?
Yeah, yeah. And I think it's worth acknowledging that when we're in pain, we are hardwired to consider pain to have a biological root, because normally when we hurt ourselves, and all the experiences we have hurting ourselves when we're young, you're running, you fall, you skin your knee. There's a very clear cause of why you're in pain.
For the
And
stove and you
the
scald
stove,
yourself.
the hot hand. Yes, exactly. And so our brains will jump to that automatically. So it can feel very abstract, especially when we're actively in pain, to think that the brain is involved and that a brain-based solution could possibly bring us down out of that. What I always think of, just going back to my experience in the clinic again, is that a lot of times when people would come to me and say, like, I'm in 10 out of 10 pain, everything, everything is aching, and I don't even know how to get started here in physical therapy. We'd often start to suss things out a little bit more. And the specific example I'm thinking of in clinic is within the same week, I had two young women in their 30s come in, both with, as luck would have it, a left rhomboid strain from fairly similar activities. Yes. Right here.
Wow. It's the place that whenever I give these webinars starts to hurt because I'm talking about pain for so long that my body starts to like, woo!
Exactly. Yes. Yes. But so these two women came in, and one of them was in a really positive relationship and had a stable job, was looking forward to upcoming vacations and stuff, just the topics that come up on the table as you're chatting with somebody. And she got better in 3 to 4 weeks, pain entirely gone. And maybe it was the stellar exercises I gave her. Maybe it was just, it needed a little time to calm down, and it did. The other woman I was working with was actively going through a divorce. She was getting sole custody of her 2 children. She was having to work overtime. And so as we continued to talk and get to know each other, it became clear that, it is about the pain, but it's not. Her intensity stayed at an 8 out of 10. We kept working together for about 8 weeks until I was done with that particular rotation, and she was still coming in. And at the time, I didn't really have the tools to try to dive into any of that more deeply with her, but I was really struck by just how much high pain intensity is influenced by all the constellation around the symptom that may be going on in our body.
Yeah, it's so important. There's another piece that I think about a lot with this question about flare-ups and high pain, and that's kind of from how do we treat them. So it's actually quite interesting that one of the things we do when we work with people at Lin is help them make a plan that says, we're going to do a different set of things when your pain is like, on a 1 to 10 scale of 4 and above, or a 5 and above, and a 4 and below. So during those flare-ups, we're gonna have a different toolbox than the one we have when your pain is a little bit lower. So when the pain is flared up, it's just really hard to not feel like this is dangerous. And so what we're going to focus on then is just soothing. We're going to help you find the basket of things that are most calming, that are most distracting, that are, you know, help you remember that flare-ups have come before and they've gone before, and this one will too. But we kind of make this like flare management toolbox that's all about trying to weather the storm as calmly as we can. And then what we're going to do different when the pain is a little bit lower, that's where we do the active reprocessing piece. Because when the pain's a little bit lower, we can learn a really different way of relating to the pain that's happening in our bodies. And that's kind of the special sauce that helps our brains to learn that they don't have to signal pain. And so you don't have to have the flare-ups in the future. But I do find it really interesting that really kind of the key in treating pain from a behavioral health perspective is separating those flare-up moments and treating them really differently than the moments where we have some pain experiences that are lighter.
Absolutely.
Any other thoughts there? And I'll go ahead and get us another question here.
One final thought is just, again, going back to kind of how our medical system is structured. And I don't place blame on any one entity in the medical system for this. We have various parts of it, from healthcare providers to insurance to hospital systems, that create the model we have now. But most people have, about 15 to 20 minutes with their medical provider. If you're lucky, you can have a little online portal access with them too. Doesn't leave a lot of time to really suss out all of the factors going on in your life when you're in pain. And so the easiest thing a lot of times is, I'm your doctor. I want you to feel better. I can prescribe you something if you like. And when that prescription helps, wonderful. When the prescription doesn't help, then I start to think about, all those other factors around. Where are you not being heard in those factors, and what of those can we address?
Yep. I so agree with that. All right, another question here, and just letting people know, make sure you are putting questions in the chat. We'll pull some more live ones in just a couple minutes here. In about 5 minutes, we'll start pulling from your questions and kind of go towards the end of the hour here. I love this one. I've learned everything about fixing mind-body pain. So mind-body is another term that's used for this learned neuroplastic pain. So I've learned everything about fixing mind-body pain, but I'm still not getting better. Why? What's wrong with me? So I love this question because it really gets to the core of why I wanted to build Lin Health, which is not because the information isn't available. If you Google mind-body pain or TMS or neuroplastic pain or neural circuit pain, or centralized sensitization, Jordan, what other words have I forgotten? They're all kind of in the same bucket of primary pain. I think that gives you a pretty good list.
I think you got all the heavy hitters, yeah.
You find a ton of people out there talking about pain reprocessing therapy and EAFT, just kind of all of the approaches that do have a really strong evidence base behind them. Evidence base means research that shows that they work. There's a great resource called the TMS Wiki. You could read a book by Dr. John Sarno or Howard Schubiner or Alan Gordon. They've all written great books on this topic. But that said, for some people, just getting the information and it's really amazing, like boom, that's enough to turn the pain off. And if you're one of those people, I'm so glad you Googled and found out what was happening and were able to get your pain to settle down. But what we see day in and day out at Lin is that for most of us, the information's not enough. And I knew this as a psychologist, like treating panic attacks. The information about how you treat a panic attack is really pretty simple. You go out and you help people gradually get exposed to the thing that they're feared of and understand that the panic attack is just a sensation, and slowly over time they go away. Same with treating sleep disorders. What you basically do to treat a sleep disorder is kind of simple. You help people restrict their sleep enough until their natural rhythmic clock kicks in, and then they sleep better. But it's not the information that's the key to getting better. The key to getting better is in the implementation of the information. And it is so, so hard to be one's own best mirror and one's own cheerleader and one's own guide and one's own ability to see the nuances of how you're applying something and where you're thinking about it on one's own. And so we built Lin, yes, to have this information and to bring the information that has the strongest science behind it out, but also we built Lin so that you would always have a real live person. And most of our coaches actually have been on this journey themselves or with loved ones. So a real life person who really sees and understands the nuance of the journey and can help you figure out why isn't this working? Like, what am I doing wrong? Where is the nuance of the doing of it that I need to switch a little bit to get these techniques to work for me. What about you, Jordan? Thoughts on I've learned everything about fixing mind body pain, but I'm still not better?
Yeah. So I come at a lot of these questions around mind body pain from the perspective of having a couple of really close family members who, including one of my parents, who has had chronic pain for years and knows plenty about this stuff, has tried many, many different things, and has had varying success with all of it. And at the end of the day, I do think that where the real value of sitting down and really talking about all of these things and revisiting the basics and looking at everything spread out in front of you, and also just giving you as a person a chance to talk about all of these things anew, is that you can reflect on these things, you can fine tune, you have the gift of time to really be able to adjust things a little bit at a time. Because for many of us, when we've been studying this stuff for so long, when we know so much, when we've seen 20, 30 different specialists, it's like a middle school brass band practicing in our head as we're trying to think about all of these different solutions. And there's so much there. So really, at the end of the day, it's kind of filtering through the noise, finding the pieces that are most important for you and for your experience. And I do think that that's what we strive to do at Lin.
Absolutely. And I'll add one more piece. One of our coaches has the loveliest way of saying this. It has to do with hope. And, when you're in pain, especially when it's flaring up, it is so, so hard to maintain hope that actually this time I might be on the journey that's going to get things better. So our coach, this particular coach, says all the time, look, my job is to have enough hope for the both of us. And your job is to show up and come get all the hope you need from me. And that is something that the book just can't do in the same way as a live person who's there for you and genuinely cares about you and is in this journey with you. So we're going to talk some more about the coaches in a minute, but I've got one last question. I just I want to make sure we address here, because I think it was so surprising to me, the answer, as I first learned this. So the question here, I have chronic fatigue syndrome. Can you help? And on the surface, chronic fatigue, what does that have to do with pain? But Jordan, I'll let you start on this one, because I know you have lots of thoughts here.
Yes, absolutely. So one of the ones I think is most helpful for conceptualizing about not just pain, but also chronic fatigue syndrome in particular, is the work of Lisa Feldman Barrett, who's a neuroscientist who studied of emotions and the brain's processing capacities, kind of turned over the world of neuroscience about 10 years ago and is continuing to do so. She's fascinating. One of the biggest things that she got out of her research was this term of the body budget. Our brains take in 40 million pieces of information per second. We're only aware of about 40 of them consciously.
Crazy.
Yeah, no, it's insane how much our brains are doing below the surface. And our body budget is basically a state of the nation. It's a state of our resources internally, including how much glucose we have to be able to continue doing activities, how much basically the level of agitation in our nervous system is another one. The amount of water we need, a lot of just basic needs and basic regulation of the body is all being monitored all the time.
Yeah.
When one has chronic fatigue syndrome, it's like your brain no longer has a good idea of what your body's resources are. And there are a lot of different reasons for why that occurs. But just to put simply, chronic fatigue syndrome and the way out of it requires a little bit of retraining of that perception of fatigue, right? We were talking earlier about, Abigail, about pain as a perception. That is an interpretation by the brain. Fatigue is no different. The sense of exhaustion, especially if it's a chronic sense of exhaustion, things that seem like they shouldn't completely exhaust you do. It's, okay, this is the brain's interpretation of things right now. The choice we have is how much is that interpretation currently serving us? And what can we do to try to correct that interpretation if we decide we want to?
Really interesting. So that also, just to kind of float this out there, there's a whole bunch of other kind of symptoms or experiences that fall into the same kind of bucket. Irritable bowel, migraines, tinnitus, vertigo. And I just float those because, again, I wouldn't have thought any of those had anything to do with the same root cause, which is this neural circuit, this brain processor that needs kind of a reset. So I'm going to pull some questions that have come in live here for our last 15 minutes. So I hope nobody minds not having slides, but they're live, hot off the chat. So the first one I want to talk about, and I always do this with a little caution because our intention here is to tell you about Lin, but no hard sell here. But I do, we've had a few people asking, what does the Lin program consist of? Please talk about the Lin coach approach. And so I do want to address that heads on for a minute. So Lin is an evidence-based program for treating chronic primary pain being all of this kind of pain that has a learned brain component to it, which is the vast majority of pain experiences that persist, is what the medical science is showing. And then really specifically, maybe I'll just kind of say the steps in the program, and then Jordan can talk some more as a coach about what our coaches are doing day in and day out. So the program starts with an evaluation for primary pain. We do want to make sure two things. A, that you're at least a part of your pain experience is primary, because we want to know we're going to be able to help you. And we also always like to check that there's no red flags, that there's nothing happening that we say, no, right now we don't want to push this off. We do need you to be working with a medical provider about X, Y, or Z, because there's something in your presentation that makes us a little concerned that there could be something that needs acute medical attention. And so we do, everybody starts with a consultation with one of our medical providers. And then out of that consultation, both we find out, yes, you do have primary pain. Congratulations, you have the best pain diagnosis out there because it's the most treatable, or you don't. Although, again, most people, by the time they're getting there, already kind of have a hunch that this might be what's going on. But we also come out of that consultation with a care plan, which is the areas that you're going to be working on with your coach. And so then what your coach does is kind of two tracks of helping you. The first is moving down the core Lin curriculum and coaching program. So we start by making sure you understand quite a bit of depth, the neuroscience behind pain. We work with you to evidence build, which means to start to see that this is not just abstract knowledge out there, but to see how this actually relates to me and my pain experience. In other words, we're starting to kind of take the conscious part of your brain and wrap it around that maybe this is what's happening with my pain. And then the next piece of the program is we kind of start to transition into learning and practicing techniques that help to turn that dial down on the pain, to create a separation between fear and the sensations, the pain experiences you may be having, because over time, the more we can make that separation, the more the pain will start to go down. So we use some techniques. One's called somatic tracking. Some people do some with a mantra. Some people, there's a number of techniques that our coaches teach our members to do and practice with them. And then the last piece as we kind of move forward, actually, as we move forward for everybody, is we do what I call like flipping the viewfinder. So for most people that have been coping with pain for a while, 70, 80, 90% of their life starts to be filled with just the day-to-day of coping with pain, which can be overwhelming. And only a little percentage is left for doing the things in life that bring joy and satisfaction and smiles and a feeling of like, wow, that was a great day. And what we do is help you step by step by step work to flip the viewfinder. So I love telling the story of one of our members came to us, not just decades, but decades and decades and decades of pain. She was about in her 70s when she made it to Lin and had basically nothing but pain in her life. And her coach worked with her to get her garden going for the first time in decades and start having time with her grandkids again, and to just stand in nature, which is something she loved. And she today is the most joyful, full of passion person. And that's an incredibly important part of what our coaches are also doing. So this takes some time. It can, for some people, can be relatively quickly. For most people, that kind of piece of the program is about 6 months. And then we encourage people to stay through a whole year program, because chronic pain is a disease, right? Your brain has learned this once and it tends to want to settle back into those same patterns. And so sort of the back half of your year with Lin is focused on making sure that when you get a resurgence, we just turn it around really quickly, use your tools and get back on the path to life, until we've done that enough times together to know that you are off and have your chronic pain, in remission and able to keep it that way. Jordan, you want to talk a little bit more about the kind of day-to-day of what coaching looks like and feels like?
Sure, yeah. And just because there can be so much variation in how things get structured, I think it might be helpful to even just like go through like one or two examples just in real brevity. Yeah, but
yeah, great.
So someone I started working with recently came in, person in their early 60s, came in with fibromyalgia as the primary diagnosis, which we would say is primary pain. It is a learned pain phenomenon. And also battling a lot of feelings of depression, poor motivation around tasks. And so we started with just learning a little bit about pain. This person was like a lifelong learner, loved to learn. So started learning a little bit about pain, and then tried to move in the direction of emotional awareness and expression, because that seemed to be an area of this person's life that was really reinforcing a lot of threat for them. And by threat, I mean emotions that feel difficult to, emotions that feel difficult to express or are getting repressed frequently can contribute to increased sympathetic input in the nervous system. There's an actual physiological response when you are having emotions that are not being moved through, being processed effectively. And I often find, just, in a clinical perspective, that's often really plays a really big factor in fibromyalgia. So now this person, by the way, with that work and some work on self-compassion, which all these things just kind of revealed themselves to be important over time. I didn't meet this person and then right away think like, okay, here's my outline, point A, 1.A.B, that kind of thing. It was listening, responding. It's a dynamic process. And that often works a lot better for people, including this person, than me telling them, all right, this is what you're going to do. This is how it's going to look. Don't deviate from this. And now, last update I saw, this person's been out of pain for about 2 weeks and just started an early child development program that they're loving. And it's exactly the kind of news you want to hear, and they're really appreciating it.
Jordan, it's such a nice example too, both of kind of that there is this kind of broad basket of tools. So our coaches are always pulling from tools that have really strong evidence base, but they're there to help you sort out what's the right tool for you at the right time. Because it's not just the knowledge, it's also the doing it. And I'll just say on a practical front, our coaches have both live conversations and lots of interaction over a messaging within our app, and then also supporting your learning as you work on the content that they handpick for you. And we do it that way because it's too long to have a session like in the traditional way you would do therapy, where you have a session and you wait a whole week. Like pain will bite back before there's time for us to stay on top of it that way. So our coaches want to be a very, very live presence in your life. And in fact, our coaches are interacting with our members on average every 2 or 3 days throughout their tenure at the program. Again, sometimes on a live call, mostly via chat and messaging. But it means that your coach is really a presence in your life and really knows you. We do also cap how many members our coaches work with. Our coaches will never have more than about 40 people total that they're working with. And we do that because we want them to know you and be invested in your life and care about you. And, when your name comes up, be like, oh, Susie, oh, Tomas, I know that person's story. I care about them and I love being on this journey with them. So we've got about 5 more minutes here. And I think what I'm going to do is give some quick answers, and then we'll do one more kind of meaty question. So what is your overall success rate for people who come to you with help? So 90% of people who come to us are experiencing some kind of a positive change within their first 4 months. Their life is more satisfying, their pain is down, they're more able to cope. And we use that metric because we know that that's the leading indicator that the pain will also settle down as those things are happening. And longer term, it is 70–80% of folks who do experience a meaningful shift in their pain, as well as improvements in their life. Next one here, I just want to address real quickly. Does joint pain, and especially foot and back pain, get worse with menopause? That's a really good question. It's one that's kind of near and dear to my heart as somebody who happens to fit in that category and happens to have had some joint and foot and back pain. I'm pretty sure this is like the whiplash study. Maybe there's something about menopause that makes us a little bit more likely to be sore, our bodies to feel a little bit different. But as soon as we've heard that those things go with menopause, then all of a sudden the fear gets high. As soon as we've heard that a little bit of weight gain is going to put us at risk for plantar fasciitis, the kind of normal tingling that somebody might get here and there, or the normal whatever from a long day of walking, can start to be read as dangerous, and that can accelerate the process of it becoming a chronic primary pain challenge. But I'm not aware of a lot of studies that are saying that the biochemical changes of menopause are driving.
Back to belief for a moment, a really interesting cross-cultural study of women going through menopause in the US versus Japan found that primary symptoms we consider to be menopause associated here, hot flashes, symptoms associated around mood, joint pain, etc. The primary symptom for women in Japan is shoulder pain. Like someone's like, oh, you're going through menopause? Watch out, that kind of thing. Which is not an instant, it can happen here, but it's not a primary one. So just an example, there's nothing different about the shoulders of women going through menopause in Far East Asia. It is more to do around beliefs and the cluster of symptoms we put around certain diagnoses or certain processes in life.
Absolutely. But I'm telling you, we're sitting here talking about menopause and hot flashes, and I'm starting to sweat just.
Oh no.
Power of our brains, huh? Actually, I think it's really hot in my room right now, but All right, last question for today's webinar. But I do want to tell people that our team is here to answer your questions. We love answering questions. We love getting on the phone and talking with you. Really, really encourage you. Shoot us a message. Make sure we have your number. If we weren't able to get back to you and fully answer your question now, we're happy to. And just be able to directly have a conversation. Our onboarding team knows a ton about all the things we've been talking about here, and would really welcome the chance to help answer your specific questions more. All right, so the last one for our last minute of the webinar here. My pain is only when I walk or stand. Does this seem more likely that there's something biomechanically than pain memory?
Yeah.
No. Go ahead, Jordan.
So Tara actually did a really beautiful job answering this in the chat itself. But for those of you who didn't see that there, I'll just basically talk about what she was talking about here, which is hard to say just off of that short description, but very potentially, particularly if it's been really resistant to classical PT, or if they haven't found something super pathological and wrong on screening and x-rays. Basically, if they haven't found anything that they could potentially find in a person with healthy pain. Another thing I always think about too in this diagnostic process is the pain reproducible all the time and in a very specific place associated with a structure? Or is it kind of all over in the legs? Is it pinpoint, basically just sussing through all of the different qualities of it helps us to sort into primary and secondary. And this is actually going to be a conversation that we'll be having in the next webinar. I don't know if that's where you were going with it, Abigail.
Yeah, I was absolutely going there, and also going to that. This is why we do these diagnostic consultations, because it is important to, while it doesn't mean that it's biomechanical rather than pain memory anyways, it's important for us to really kind of sort that through with you. So this is the official end of our webinar, but people are welcome to stick around if they want answers to other questions from our team. We'll keep the chat open. And thank you all so much for participating. It was really, really good to have you here today, and hope that we can have gotten you something to think about and that we can be a help as you're moving forward. Have a great day.
Thank you all.